Fitch. This video would be posted on January 22nd, 2025. We are going through this issue of JAVMA. It is March 15, 2017. What is your neurologic diagnosis? We have an 8-year-old, 63-pound, female spayed, border collie mix, progressive left thoracic limb lameness, 1-year duration. There was diffuse atrophy of the musculature of the left thoracic limb with carpal joint hyperextension and grade 2 lameness on a scale of 0 to 4 on physical exam. On neurologic examination, there was monoparesis of the left thoracic limb. When they tested postural reactions, which are the ability of the body to detect where its limbs are in space, the left thoracic limb was the only abnormality. It was weak on hopping, postural proprioceptive positioning, hemi-stand walking. It was deficient, as well as spinal reflexes of the extensor carpi and inflection of the left thoracic limb. And so that gives you the anatomic diagnosis of either the C6 to T2 nerve roots, C6 to T2 spinal cord, like a myelopathy, or a disease affecting the elbow joint or carpus, like arthritis. So the left brachial plexus involving the C6 to T2 nerve roots or the C6 to T2 spinal cord segments are suspected. Differentials include neoplasia, disc disease, neuritis, discospondilitis, degenerative joint disease, trauma, hypothyroidism, and hyperadrenocorticism, also known as Cushing's, were all possible differentials. They performed radiographs that showed a mild narrowing of the C3, C4 intervertebral disc space, but no mineralization or osseous lesions. Left shoulder ultrasound showed atrophy of the supraspinatus and infraspinatus muscles. There was mild focal mineralization of the supraspinatus tendon at the point of the insertion on the greater tubercle of the humerus, indicative of degenerative joint disease. The intervertebral discs appeared normal, and there was focal enhancement of the nerve roots at the level of C6 to C7. This is on MRI, by the way. So on MRI, the discs look normal. Focal enhancement of nerve roots at the level of C6, C7. There was as they emerged from the spinal canal, the C7 nerve root was diffusely enlarged, 5 to 6 centimeters in length, as it exited the spinal canal on the left side. And here you can see the arrow is pointing to a contrast enlargement of that left C6, C7 spinal nerve. So they suspecting a nerve sheath tumor, probably. They amputated the left thoracic limb, and they did a left-sided hemilaminectomy at the level of C5 to C7. The C7 nerve root had an enlargement confined by the nerve sheath. The C6 and C7 nerve roots were grossly enlarged. Expanding the C7 nerve root was a non-encapsulated infiltrative highly cellular neoplasm of spindle-shaped cells arranged in streams and bundles with dense fibrous stroma. The mass effaced existing axons, but was confined by the nerve sheath. The neoplastic cells had moderate amounts of poorly defined eosinophilic cytoplasm and ovoid to irregularly elongated hyperchromatic nuclei with 1 or 2 large prominent nucleoli. There was marked anisokaryosis and frequent karyomegaly with many multinucleated cells, 44 mitotic figures per 10 high power field. These are all indicators of malignancy. They're all markers of malignancy. There was moderate immunoreactivity for S100 antigens, that's immunocytohistochemistry. So they diagnosed a malignant peripheral nerve sheath tumor. Comments. The pelvic limbs are affected less frequently than thoracic limbs. You can also see Horner syndrome with these dogs. There are no reported breed or sex predilection for this type of tumor. There is a point mutation of the new oncogene, that's NEU, oncogene that's been implicated in a small number of malignant peripheral nerve sheath tumors in dogs. They appear as hyperintense compared with muscle on T2 weighted images and short tau inversion recovery pulse sequences on MRI. These tumors are iso-intense on T1 weighted MRI images and strongly hyperintense on T1 weighted MRI post-contrast. Myelography, electromyography, and ultrasound can be helpful. Radiographs are not usually diagnostic but can show evidence of bone lysis. These tumors are derived from Schwann cells, perineural cells, or both. In humans, they are classified as schwannomas, neurofibrosarcoma, neurinoma, and neurolemoma. on the basis of morphological, immunohistochemical, and molecular markers. Although most common in non-cranial locations, you can find them affecting cranial nerves, most often trigeminal nerve. Immunohistochemically, benign tumors of Schwann cell origin have immunoreactivity for S100, but malignant can also have similar immunoreactivity. The prognosis is poor depending on the degree of malignancy, the location, spinal cord involvement, and complete excision during surgery. Peripherally located tumors are associated with longer progression-free intervals than those in the brachial plexus or nerve roots. Radical surgery is recommended. Recurrence can happen at the tumor site and subcutaneous tissues. Although metastasis is rare, pulmonary mets can occur. This dog developed no complications with surgery, and they declined doing radiotherapy and chemotherapy, and it eventually was euthanized 5 months after surgery for additional subcutaneous tumors that were grown. We weren't sure whether or not those masses were associated with local infiltration or regional metastasis. So the picture down below is a three-legged dog. Dogs can do very well on three legs, and of course depends on the dog. If you have a dog that's got other neurologic issues or has other limbs affected by arthritis, and it's barely ambulating on the three legs that it has, then amputation may not be the best course of action to take, in which case you either consider palliative care with a combination of non-steroidal anti-inflammatories, pain medication, maybe physical therapy or something. Otherwise, maybe you can go to chemo and radiation therapy, but these tumors tend not to be that great for those. It doesn't respond that well to those, but those are obviously options if you want to try. Otherwise, it's euthanasia if the pain becomes too much. This dog was not painful, but a lot of times in my experience with peripheral nerve sheath tumors, they are very painful, especially if you palpate right in the area of the tumor. This tumor was very close to the vertebral canal, so probably if you palpate underneath the axilla, the armpit region, it may be too deep in the tissues to elicit pain. But they didn't comment on that anyway in this paper. But that's a cool paper and an interesting tumor type. So thanks for supporting the channel. We'll see you guys again tomorrow. Take care. Bye.